Hello, I am Dr. Mark Davis. I'm a naturopathic doctor for about the past 15 years and a fellow of the American Board of Naturopathic Gastroenterology. Welcome to my lecture on fecal microbiota transplantation. My target audience is other naturopathic doctors and all stripes of integrative clinicians who are interested in the topic. So here are my disclosures, and the top two in red here are genuine conflicts of interest that you should keep in mind. So I am a partner and co-founder at an FMT bank used for clinical purposes in Panama, and I'm the sole proprietor of an FMT bank here in the US that we use to provide to individuals for their own personal self-research into microbiome alterations, but for non-medical purposes, all non-medical claims on the website, etc. Here are a bunch of consulting disclosures, just groups that have at some point paid me a consulting fee. Sometimes groups asked to disclose consulting fees within the past year. None of these have been in the past year. And then these are my affiliations. So I practice telemedicine in 4 states and do remote educational consults all over the world at foundational-medicine.com. And we put together lots of classes on integrative care of IBD and other things. So education is a big part of what we do. I teach the naturopathic gastroenterology class at Sonoran University of Health Sciences. I'm on the board of directors and I'm the chair of the research committee at the Gastroenterology Association of Naturopathic Physicians. And I'm also a partner in Anthera VMT, which provides vaginal microbiota transplantation. So thanks to, there have even been many more people than this who have vastly influenced my thinking. And in the middle is mostly medical doctors, all people who've given me excellent advice, or I've met and chatted with at conferences and have given me various degrees of guidance. And on the outside in green here are naturopathic doctors who've influenced my thinking a lot. And I've got to give extra thanks to my two co-partners at Foundational Medicine. So these slides are very information dense and got a gajillion references at the end. So I'm going to go through giving this talk by just highlighting the most important things on each slide. And to the degree that you're interested, you can go through and pause things, look at slides more carefully, more in depth, look at the references, etc. But I'm just, for the most part, going to highlight things in green. And there's so many clinical trials of FMT now that all the research I cite is clinical trials in humans, unless I specifically mention an animal trial that I think I do once or twice. And I'd consider using FMT with every condition of the group that I describe here in the indications section. There are more trials in the literature that describe FMT not helping. For example, in psoriatic arthritis, the one trial of FMT for psoriatic arthritis found FMT was significantly worse than sham, which, pretty much matches up with my experience. I've used FMT with one patient with psoriatic arthritis. I don't know if he got worse, but he didn't get better, I can tell you that much. So even though there are some conditions with low efficacy that I'm going to talk about in specific detail, I would consider using, you'll see when I get to that part. Okay, so today we're going to review the history and mechanism of action of FMT, talk about safety and efficacy for a variety of conditions. That's really the bulk of the talk. Talk about politics and availability, and then various naturopathic or integrative support options for your patients who are doing FMT in some fashion. Okay, history and MOA. So 400 AD, Ge Hong described oral suspension FMT in the handy therapy for emergencies. In the 18th century, and there's actually a lot more in this history that I'm not mentioning. There's a lot of Asian history in China and the Korean Peninsula throughout the centuries. But in the 18th century, Christian Franz Paulini describes oral suspension of FMT for GI conditions. Note, he also described the use of PO falcon poop to improve eyesight, and a lot of other things that sound bizarre to me and I don't think are true. So we can't take all this old science, without a grain of salt. 1958, we get into kind of present day science where Eisman et al. Published fecal enema as an adjunct in the treatment of pseudomembranous colitis. And by the way, I don't have time in this talk to go into the details, but really they got this idea from the Chinese medicine literature in a little bit of a roundabout way. 1989, Brody reported using FMT in 55 patients with IBS and IBD in a letter to the editor. And then this is a little tuning my own horn, but I started naturopathic medical school in 2006, and I used FMT for the first time while I was a student. I quickly became obsessed with it. 2012, Open Biome was founded, a large nonprofit FMT bank. 2013, FDA regulated FMT as a drug with exceptions. The main exception that persists to this day, and probably will be a durable exception, is that clinicians are able to prepare and utilize FMT for their patients with C. diff colitis not responding to standard therapies. That's the big exception. You don't have to treat FMT like a regulated drug in that context. And then just in late 2022, early 2023, the first FDA-approved FMT drugs were approved. Rebiota, which is FMT enemas, and Vowst, which is FMT with everything in it killed but spore formers in capsule form. So that's kind of a timeline of FMT over the centuries. So what is FMT? This is any stool products or extracts made from the stool of healthy screen donors, and it's usually used to engraft the donor microbes to the recipient's microbiome. By engrafting, we mean that the microbiome of the donor influences and sticks around in the recipient's GI tract. It can be administered via enemas, like pictured here, upper endoscopy, lower endoscopy, aka colonoscopy, or rectal tubes, capsules, and there's actually been several trials just using a PO therapy, putting little filtered aliquots into chocolate milk or chocolate almond milk, things like that. So these are the different administration methods. And in an interesting broader sense, FMT can happen accidentally. The famous American microbiologist once said, the entire world is covered in a thin patina of feces because fecal microbes are everywhere. And so even without fecal transplant, living in a household with other people, your GI microbiome tends to resemble theirs over time, especially if there are pets in the household. People's microbiomes will resemble one another's even more often with romantic partners than with non-romantic partners. So we are sharing our GI microbiomes through the omnipresence of these microbes over every surface, in the air, up into the stratosphere, down into the deepest layers of Earth that we've looked. There are microbes everywhere. And how I think about using FMT. So I think of it in a few ways, and one important way is in harm reduction. There are estimated by some sources, tens of thousands of people per year doing FMT at home with their own donors from donor banks, a variety of sources. And I am often counseling people on doing DIY FMT. They say, hey, look, Dr. Davis, I contacted you because I am planning to do FMT from my spouse or my kid or my parent or my neighbor or whoever. And I want them, if they're going to do it with the highest safety and best chance of benefit. So, sometimes we think of harm reduction. If there are recreational injection drug users, you as a clinician want to step in and make sure that they have access to clean needles and they know not to share them, and their hygiene, and they're doing best practice around it. So, so at the very least, what we're doing is making sure our patients who are doing FMT are doing it in the safest way that they can, reducing potential harms, even though it is a very safe therapy. I also often talk with my patients about risk-benefit ratio. And I am interested in talking with them about risk-benefit ratio if we're talking about a diet or a drug or a supplement or an herb or whatever. So sometimes the risks in terms of quality of life from a diet can outweigh the potential benefits. So I say, yeah, that diet could help you, but it's probably, the juice isn't worth the squeeze. And for FMT, the known risk of serious adverse events is tremendously low. It's very low. And do all my patients who do FMT get benefit? Of course not. Of course not. Sometimes patients have very, very high hopes. They feel like they've tried everything and they just want to try something they've never considered before that seems radical, and they'll try FMT and they don't get any benefit at all. Sometimes patients think they're getting a benefit initially, and I think there is a strong placebo response with FMT because it is so radical and different. And so sometimes patients will report an initial burst of energy and improvement of mood in the first few days that then starts to wane over the next couple of weeks. And sometimes patients get big bursts of energy and improvements in mood that last. So anyway, in terms of the risk-benefit ratio, I many times have had patients say, will this help me? And I have to say, I do not know. I do not know. I can't even give you the odds because your condition hasn't been studied in the literature. But based on my benchtop translational medicine, knowledge of physiology and microbiology and immunology, it is possible that your autoinflammatory, autoimmune, hyperinflammatory condition could respond to an abrupt microbiome change. And the risks of serious adverse events are very low. So if your quality of life is low, your pathology is bad, you are willing to work hard and maybe take small risks to get improvement, often the juice is worth the squeeze. All right, so we'll talk about what's in the literature, but I will think about FMT for any pathology that may be driven by the places where the microbiome and the immune system interact. So that's not all pathology, but it's a lot of different pathologies. So sometimes I will work with people with unclear diagnoses, or diagnoses where FMT has not been studied for that diagnosis in the literature, and I'll still try it out based on this kind of thinking. So I think of it as like diet level kind of safety, not more safe than when using a properly screened donor. Very, very good safety record. So for a very safe therapy, this leaves a lot of room to play with even things that are outside the literature, in my opinion. And again, I think I have a note on this, conflict of interest. I am saying these things because this is genuinely how I think as a clinician, but I have financial involvement with FMT labs, and so keep that in mind. Do I have some bias? I'm very biased towards FMT. I've used it thousands of times. I've seen amazing results. I'm a big fan. So I'm biased. Keep that in mind. And I'm going to try and give you my most unbiased presentation of the literature as I can here. Okay, so what are the mechanisms of action? So mostly, maybe entirely, the benefits are from the engraftment of healthy donor microbiota. So for example, when you have bacteria with bile salt hydrolase or BSH activity, that bile salt hydrolase activity keeps C. diff, a spore former like all Clostridia, in its spore form. So it can't become vegetative and start producing toxins. So that is a benefit by these particular strains of bacteria engrafting and having this activity keeping C. diff in spore form. Also, bacteria with BAI operons, bile salt inducible operons, are creating secondary bile acids and inhibiting vegetative C. diff growth. So not just keeping it in spore form, but actually inhibiting the growth of C. diff that is out of spore form and in vegetative form. Another example is bacteria like Faecalibacterium prausnitzii or Roseburia or others that are producing short-chain fatty acids like butyrate. These bacteria being engrafted and alive and part of the patient's microbiome, that is benefiting patients with ulcerative colitis, for example. Some of the benefit, we think, is the reduction of harmful endogenous microbiomes. So not just the activity of beneficial microbes, but the fact that they are crowding out harmful things. So for example, reduction of Candida species is associated with better outcomes with FMT for patients with ulcerative colitis. Reductions in Enterobacteriaceae is associated with better outcomes in C. diff, ulcerative colitis, hepatic encephalopathy, and more. And then reduction in norovirus is associated in better outcomes for patients with refractory diarrhea who get FMT. Non-bacterial stool components. So there have been at least 3 trials, I think 3 trials, where FMT is filtered to 22 micrometers. So that's excluding all bacteria. So for sure, that is not about bacterial engraftment, right? But it still appears to benefit patients in some ways. So there's a trial where FMT filtered like this benefited C. diff patients, but then a recent RCT that only prevented recurrence 65% of the time versus 88% with bacterial FMT. So preventing recurrence of C. diff 65% of the time, that's not bad. That's not bad, but maybe not as good as bacterial FMT. And this non-bacterial FMT may benefit patients with ulcerative colitis also. Is this because of beneficial viruses like bacteriophage? Is it because of postbiotics? Is it because of something else? We're not sure. More C. diff bacteriophage is associated with a higher cure rate in patients who get FMT for C. diff, with more of that C. diff bacteriophage in grafts. And then there's anecdotal benefits with a product that's a postbiotic autoclaved donor stool. This is a company I'll mention at the end in the practical cost and pricing slide. And I have a great impression of them. One of the co-founders was a former student who had worked with me. So I'm not financially involved with them anyway, but I'm very fond of them. So that's the postbiotic autoclaved donor stool is not yet in the peer-reviewed human literature. But those metabolites in autoclaved donor stool, in my mind, are almost certainly relevant and can benefit people sometimes. All right. And then I won't spend time on this slide, but I do think that there are times when just introducing a whole new set of bacteria and other microorganisms to the gut forces the immune system to change its relationship with those microbes. Even if they're not from a super donor or necessarily the filling certain metabolic niches, just that act of introducing a bunch of new microbes forces a little bit of an immune system reset and can benefit patients some ways like that. All right, so here comes this next section, the bulk of this talk, indications. And I'm going to focus on the most efficacious and prevalent conditions that FMT has been studied for. So here's my chart, and here in green are the most efficacious and most prevalent conditions that FMT has been studied for. But I also am going to touch on everything here, just not as robustly. So these are the conditions I've used FMT for the most, myself as a clinician. Refractory C. diff infections, inflammatory bowel disease, that's most of my practice for many years. I've worked with neurodegenerative conditions, chronic idiopathic, sometimes severe constipation, autism spectrum. I've been peripherally involved in quite a few cases, although that's not usually with my patients. IBS, of course, because it's so common. And I have worked with pouchitis and ALS patients. I'd say about half a dozen of each, even though I don't have much benefit to report, and there's not much benefit in the literature either. We'll talk about that. A couple of conditions that are low prevalence but appear to be high efficacy. These are ones I have not worked with either much or at all, but I would love to be more involved with FMT for severe alcoholic hepatitis because the literature is so overwhelmingly convincing to me, and for oncological indications. Again, I've been peripherally involved with some cases that I'll talk about. And then here's other conditions. High efficacy, high prevalence conditions. I would love to use FMT for more, but I haven't really much. One is major depressive disorder. You'll see the literature later. Refractory urinary tract infections, and then multi-drug resistant organisms. So I'll go through all of this literature now. Starting with the high efficacy, high prevalence ones, and of course starting with C. diff. Most of you attending this lecture are probably have some familiarity with FMT for C. diff. The literature has been very exciting over the past 15 or 20 years. So I'll go through this relatively quickly. FMT has an 80 to 90% or higher cure rate at treating antibiotic-resistant C. diff. It's better than antibiotics, either 50% or maybe even as high as like 80 or 90% higher than antibiotics. Lower recurrence rate after successfully treating C. diff with FMT versus antibiotics, and robust safety signals in the United States and several other countries. Can FMT be used as a first-line therapy instead of antibiotics? So that is to say, not for antibiotic-resistant C. diff, but as a first-line therapy for C. diff infections that have not yet been treated with antibiotics. It does appear to have been superior to vancomycin in a 2020 retrospective trial and non-inferior to vancomycin in a 2025 prospective trial. So I would say yes, and I have used it successfully for that indication myself. And for severe C. diff infection, giving FMT as a first-line therapy along with antibiotics, that is to say, you're not giving antibiotics, letting them fail, doing that once, twice, 3 times, and then giving FMT. You're giving it with antibiotics as a first-line therapy. Dramatically improves mortality rates. Giving FMT to 2 patients with severe CDI saves 1 life at 3 months. So very low number needed to treat. And it is safe and effective to treat C. diff in IBD patients with active IBD and those in remission. So again, this is for C. diff. Can you give FMT to IBD patients with C. diff? The answer is yes, it's safe and effective. Now moving on to IBD. This is more than half of my own clinical practice. And so we'll talk first about ulcerative colitis and inducing remission. Not maintaining, but inducing remission. So pretty recent meta-analysis of randomized controlled trials for ulcerative colitis, 600 subjects, revealed a significantly higher combined clinical and endoscopic remission for patients getting FMT versus those getting placebo. Nice low p-value. And, also for clinical remission and endoscopic remission separately, but the combined is what is most interesting and important to me. Adverse events very low, similar between the placebo group and the FMT group. More effective when a bunch of anti-inflammatory IBD treatments are used as pre-FMT treatment. And then another overview of systematic reviews of FMT for ulcerative colitis looked at 12 trials, 544 subjects, and found that clinical and endoscopic remission of FMT was 52% for clinical, 34% for endoscopic, versus 16% for clinical and only 13% for endoscopic for the placebo group. And this is an older overview here, but it, unlike this more recent one, it broke out clinical and endoscopic remission rates for the 2 groups, which I love because it just shows how dramatically different they are, which is absolutely what I see in my clinical practice as well. And FMT may reverse cytomegalovirus colitis in kids with ulcerative colitis a third of the time, which is great. Okay, so that was inducing remission. What about maintaining remission using FMT as a maintenance therapy? Colonoscopic FMT every 8 weeks for 48 weeks did lead to higher remission rates, clinical, serological, and histologic remission. 1 FMT capsule per day for 12 weeks also led to higher remission rates. Very small study. 2 out of 6 remain in remission in the FMT group versus 0 out of 6 in the placebo group. And lower fecal calprotectin in the FMT group. That did not quite reach statistical significance, P of 0.08, but it was pretty close. Close enough for government work, in my opinion. And enemas and caps may be equivalent for maintaining remission. So whichever is logistically preferable for you and your patient. So my take home from FMT pre-treatments improving outcomes is anything to decrease inflammation helps. So that could be steroids, biologics, 5-ASA drugs, like we saw in the previous slide. But that also can include many non-prescriptive therapies or off-label prescriptive therapies that are not FDA approved for IBD, but that integrative clinicians are using routinely in their practice. That could be turmeric, it could be wormwood and EGCG, it could be low-dose naltrexone, it could be diets. So bringing down, that's my own opinion, bringing down inflammation with whatever method we have before FMT, you're going to improve your chance of a good outcome. That being said, you do not need to wait until ulcerative colitis inflammation is controlled to start with FMT. Absolutely. It can sometimes be very effective for poorly controlled UC, although in my experience, it tends to need more doses. So I've worked with many people with very severely active ulcerative colitis, 20, 30 or more bowel movements per day, a lot of bleeding, anemia, etc. And I'll talk about, I think, one of those cases in these slides. Okay, this is one of those cases. So this is a patient of mine, 26-year-old male with a 1-year history of ulcerative colitis when he presented to me, complicated at that time by recurrent C. diff colitis, responsive only to difficid. He was on Acecol and Humira when he came to saw me. He was underweight. He was having 4 Bristol 5 bowel movements per day, no blood, mild urgency, and C. diff positive. I gave him 1 FMT enema per day for 5 days, and by the end of treatment, he reported having 1 bowel movement per day, which was Bristol 3 to 4, and no urgency, no blood, no mucus. So great outcome. He remained in remission for 7 months. There were some ups and downs, but basically remained in clinical remission for 6 years. Then after that time, he gave me a call. He was traveling with friends in New Orleans, stuck at a hotel with up to 40 bowel movements a day, not sure if it was C. diff or ulcerative colitis. I sent him 2 bottles of FMT caps, 35 caps per bottle, took 35 caps on day 1, 35 caps on day 2, and within 48 hours, that brought his stooling down to 2 to 3 bowel movements per day. So this is a great case. Okay, Crohn's. So in a 2023 meta-analysis of FMT to induce remission, looked at 11 cohort studies in 1 randomized controlled trial and found 57% achieved clinical remission within a month. Amazing. And then a 2025 randomized controlled trial, and bring that up separately because it was published after this meta-analysis, found FMT was non-inferior to immunosuppressants, including corticosteroids, thalidomide, and azathioprine, to induce remission in kids with Crohn's on partial enteral nutrition. Another randomized controlled trial looked at maintenance, not induction of remission, but maintenance of remission. 1 single colonoscopic FMT found 88% steroid-free clinical remission in the FMT group at 10 weeks versus only 44%, half of that in the sham group. And then at 6 weeks, CRP increased in the sham group significantly, but not in the FMT group. And how about how often to redose? So for that group of Crohn's patients who are FMT responders, redosing at 4 months or less may be ideal. This is a case of mine. This is a 14-year-old male with a 2-year history of Crohn's ileocolitis. Had to reschedule 2 appointments and flights from the Bay Area to my office in Portland because he needed to go inpatient for dehydration and blood loss due to his recurrent C. diff infections on top of the Crohn's. He had never been in clinical remission since his diagnosis, despite being on infliximab when he came to see me. He finally made it to my office and had 35 FMT caps per day, PO, of course, for 2 consecutive days. And I told the family, I think this dose will only be enough to cure the C. diff infection. Probably won't impact Crohn's. To my delight, I was wrong. This young man did enter clinical remission for the first time since his diagnosis, rapidly gained weight and stature to age-appropriate norms, which is amazing. And he was still on infliximab the whole time, and then he was lost to follow-up to me. But still a great case. I saw him for maybe a total of 6 months. Microscopic colitis. Is this the minor inflammatory bowel disease? Is it not inflammatory bowel disease? We can debate nomenclature, but I include it in this section. I, myself, have used FMT with 7 patients with microscopic colitis, using either 5 FMT enemas or 10 FMT enemas, and in that group, 3 out of 7 patients reached clinical remission within a month of FMT. What to make of that? I'm not sure, just me reporting what I've experienced. And here is a case from the literature. This isn't my case. Really cool case. Used 3 rounds of FMT enemas per day, one FMT enema per day for 5 days over the course of 6 months. In this case report, they say the patient generally felt better for 2 weeks after the first FMT without any change in number of daily stools. After second FMT, about 6 months later, the patient felt an improvement with loose rather than watery stools per month. And then after the third FMT, a couple months later, a remission was achieved for 11 months with 2 normal stools. So that's a great outcome. There was a case series using 1 enema every 2 weeks for a total of 3 doses, which had meh results. So 1 enema every 2 weeks for a total of 3 doses showed benefits on some scores, but not an overall stool frequency. And as you know, if you work with patients with ulcerative microscopic colitis, overall stool frequency is the biggest driver of quality of life. So I would say this dosing is, who knows why we saw such meh results, but certainly one probable reason is that the dosing was so low, 3 enemas over the course of 6 weeks, versus in this trial, they used 15 enemas over the course of 6 months. So much higher dosing frequency, and that's closer to what I have used. Okay, that's it for the IBDs. Moving on to chronic idiopathic constipation. So meta-analysis of 9 observational trials from July of 2025 reported what looked like a huge win, okay, statistically and clinically meaningful improvements in quality of life, 32-point improvement on GI quality of life index, great. Bristol stool, if you're familiar with the Bristol stool scale, it goes anywhere from 1 to 7, and 1 is hard pellets that are difficult to pass, and 7 is just watery stool. And so a 1.3-point improvement on that 7-point scale, that's good. All right, moving really to less constipated. And colon transit time, 20-hour improvement, not bad. But I will say lots of mild to moderate constipation in these studies. And so the total was only about 1 additional bowel movement per week. So, this is people going from 2 bowel movements a week to 3 bowel movements a week, something like that. So it is statistically significant, and they are having improved quality of life. But when I've used FMT as a solo therapy, mostly for my patients with mild to moderate idiopathic constipation, I'm using other things. I'm using diet, I'm using magnesium, I'm using fiber, I'm using physical activity, maybe I'm using anthraquinone glycoside containing herbs. There's a whole huge list of things I'm much more likely to use for mild to moderate constipation. So unlike the people in these trials, I'm mostly reserving FMT for patients with severe idiopathic chronic constipation. So when I've used FMT as a solo therapy for that group with severe constipation, about 25% get a substantial response. Much, much lower. So I've developed this sort of a protocol where I give prucalopride, that's motegrity, starting at 1 milligram per day and increasing to 2 milligrams as needed. And then also lactulose, starting with like a teaspoon once a day or twice a day and moving all the way up to a couple tablespoons. Lactulose, if you start at that high dose, people usually get very bloated very quickly. So to improve compliance, I start at a low dose, about a teaspoon, and move up. And if and when I'm able to get things moving, ideally 5 to 7 spontaneous complete bowel movements per week for a couple months or a few months, and then I give a round of FMT, that might be 10 FMT enemas, for example, I get more like a 50% durable response. So that, still not 100%, but doubling my response rate, I'm pretty happy with that. Okay, MDRO, multi-drug resistant organism decolonization. I've really not done this. Couple recent-ish meta-analyses, mostly observational trials, report 70% decolonization rates for the major MDROs. But then a 2025 randomized controlled trial showed a 0% total decolonization rate but numerically, but not statistically significantly, lower rates of bacteremia, intestinal pathogen domination, and antibiotic use. So interesting, encouraging, would consider. Literature is a little conflicting and mixed here. On the theme of antibiotic resistant, but moving on, we can think about recurrent UTIs. So a 2023 retrospective trial looked at 5 patients with recurrent UTIs who'd had FMT for their RCDI, their refractory C. diff infection. Highly significant drop in UTI frequency and a number of hospitalized days. So in the 126 days before FMT of these 5 patients, there was an average of 4 UTIs, 15 days in the hospital, and $6,000 or more US dollars spent. And then the 126 days after FMT, 0 UTIs, 4 days only in hospital, and only $1,500. So that is great. And then 2025 retrospective trial looked at 11 patients, different patients than the first study. 11 different patients with UTIs who'd had FMT for C. diff. The average 2-year urinary tract infection rate dropped from 3.7 a year to 0.37 per year. Nice low p-value with that. So those are retrospective trials. Those can only get you so far. What about prospective trials? Yes, there was one. A prospective observational trial from July 2025 used rifaximin TID for 3 days, followed by a single dose of encapsulated, freeze-dried FMT. By my estimate, reading the trial, it's probably about 25 capsules. And a group of 22 women with RUTIs who'd had an average of 5 UTI episodes each in the 6 months before FMT. And in the 6 months after FMT, the group had an average of 1.6 UTIs per person. So this is a prospective observational trial. Great looking results. Very, very encouraging. Here's a case report on antibiotic resistance. This is not mine. About an elderly patient who was hospitalized with severe multi-organism pneumonia, and FMT helped her recover from that. Okay, mood disorders. Also, basically no experience here myself, but a recent meta-analysis of FMT for major depressive disorders, 12 trials, almost 700 subjects. They stated that FMT is statistically significantly beneficial for major depressive disorders with a greater effect size than SSRIs and benefits lasting to about 6 months. PR, per rectal delivery, more effective than per oral, more beneficial on those who also have IBS. So I, in my own practice, do not have experience with this, but what this would tell me is patients with major depressive disorder could potentially significantly benefit from FMT, especially if they have IBS, and the dosing is maybe twice per year. What else? Randomized controlled trial of a 40 microbe consortium, so like a lab-grown FMT substitute, did not differentiate from placebo. And then there's small signals of benefit for anxiety disorders and a couple of encouraging case reports for bipolar disorder, including one that got a lot of media coverage. Okay, so those are the high efficacy, high prevalence category. Now we'll move into high efficacy but low prevalence, really just liver stuff and cancer stuff. And I have very, very little clinical experience with any of this. So we're going to start with alcohol-associated cirrhosis. Clinical trials of FMT in human patients with alcohol-associated cirrhosis, substantially increasing 3-month survival rates in 3 different clinical trials, increasing 6-month survival rate and 3-year survival rate in 2 additional clinical trials in humans. Meta-analysis found that 1-month and 3-month mortality rates were significantly reduced, but I have an error here because I say 3 twice. I say 3 and 6-month not significantly reduced. Anyway, mixed evidence on this particular meta-analysis. Hepatic encephalopathy resolving in 100% versus 57% in the placebo group. P-value of only 0.1, so that's more than 0.05, not statistically significant, still very intriguing and compelling to me. Ascites resolving in 100% versus 40% that did hit statistical significance. reducing alcohol cravings and reducing actual alcohol use. And in this dose ranging trial, every dose that was tested, even as low as 1 enema or 10 caps, reduced hepatic encephalopathy recurrence from 91% down to 60%. So, wow, so compelling. Now, this isn't my patient population, but I would be so interested and intrigued to work with FMT more in this patient population because it looks really convincing. Cancer. So FMT is safe and effective at treating people with antibiotic-resistant C. diff infections or recurrent CDI who are immunocompromised, including due to cancer immunotherapy. So FMT is safe when used to treat C. diff in the population of people with cancer. And FMT has been barely studied in patients undergoing chemo, except for patients with AML in whom it is safe but does not reduce infections. But for patients with checkpoint inhibitors, the evidence is intriguing. Oh, and there was a recent lung cancer study that was too recent. I didn't even put in these slides. Meta-analysis from June looked at 10 studies using FMT and 164 checkpoint inhibitor non-responders with solid tumors, found a 43% objective response rate. That includes data from a 2023 clinical trial for colorectal cancer, which typically has a 0% objective response rate to checkpoint inhibitors. But at this point, it had a 20% objective response rate. So cancer, also not generally my patient population. So I had to reach out to my friends who work in oncology who were like, well, yeah, this is observational trials, not randomized controlled trials, but looking at that data, that looks really promising. A trial from August, so after this meta-analysis, looked at FMT and PD-1 inhibitors for people with advanced melanoma. They had a 65% objective response rate versus an expected objective response rate 17 to 45%, and a median progression-free survival rate of 30 months versus an expected PFSR of 6 to 12 months. Again, very encouraging. I remember I've got a conflict of interest. I am financially involved with FMT labs, but good Lord, if I had melanoma with something with such a good safety profile, I would absolutely myself be doing FMT 100%. And FMT resolves checkpoint-induced enterocolitis 85% of the time. Very encouraging and exciting. So you guys are probably familiar with graft versus host disease. This occurs over half of the time after bone marrow transplants for hematologic cancers. So for GVHD, a meta-analysis of observational trials suggested that FMT induces remission 64% of the time. A recent randomized controlled trial did not find reduced infection rates in the whole population, but did in the population who showed good engraftment. That is, the donor microbes were sticking around. And there does appear, like in many conditions, to be a strong donor effect. I don't talk about this elsewhere in this talk, but there's this idea of a super donor, which is only something you can identify retrospectively in trials where you say, oh, in this clinical trial, statistically significantly more people responded to this one donor. To date, we as a scientific community have not been able to figure out what makes a super donor based on their microbiome or their lifestyle or anything else about them. And then radiation enteritis. This is one of the things, there's no human models, just animal models, but FMT from eubiotic mice to dysbiotic mice receiving radiation showed less radiation damage and higher survival rates. So that's encouraging as well. Okay, so now we move on to low efficacy but high prevalence. So these are things that the literature is not very exciting, and we'll talk about specifically what that means, but they're so prevalent, you probably encounter them so much in your practice that, in the huge list of things you'd consider for metabolic liver disease, metabolic syndrome, overweight, diabetes, and irritable bowel syndrome, hugely prevalent conditions. In the vast, vast group of things you would consider, FMT is not going to be the first, not for me. But if you're having patients who are not responding to other things, or if they're particularly excited about trying FMT, could you expect some benefit? Well, maybe. Let's talk about each of these conditions. So, liver disease. FMT is safe in patients with cirrhosis, but caution if it's decompensated cirrhosis. Can reduce leaky gut in people with metabolic liver disease, so that's cool. And then in a randomized controlled trial of 75 people with fatty liver disease, liver adiposity increased in the control group and significantly decreased in the FMT group as per FibroScan. Significant changes in the FMT group were driven by lean subjects with fatty liver. So that's interesting. In terms of metabolic syndrome and overweight, not super exciting. FMT can decrease insulin resistance a bit and decrease fasting blood glucose a bit and BMI a bit in people with metabolic syndrome. But FMT from lean donors does not decrease overweight in the general obese population or in those getting bariatric surgery. There is one subpopulation who benefits: adolescents who get a single course of FMT caps, reduce visceral fat, have smaller waistlines up to 4 years later. So adolescents with metabolic syndrome is maybe our one group that we're most bullish about considering FMT with here. And then 2021, very interesting study here from Nature Medicine, was a randomized controlled trial for people with metabolic syndrome and severe obesity. And this trial had 4 different groups. So high fermentable fiber. So this was acacia, wheat starch, and cornstarch, big dose, 30 grams a day. And it's not unfermentable, but low fermentable fiber, where they just use microcrystalline cellulose, and then FMT with high fermentable fiber and FMT with low fermentable fiber. So the low fermentable fiber group with FMT was the only group of those 4 groups to get substantial engraftment. What does that mean? I don't know. I've been thinking and wondering and talking about this to colleagues and trying to figure it out, and I don't totally understand. They were also the only group to get significant improvements in serum insulin. And I mean significant, statistically significant, p.02 improvements in serum insulin. And that same group getting FMT and 30 grams a day of microcrystalline cellulose also had substantially restored endogenous GLP-1 response in an oral glucose tolerance test. So still figuring that one out, just wanted to report it to you because it's there in the literature. Diabetes, and so why do I have this in the low efficacy group? Because here we are pulling out subgroups. We can say FMT from lean donors does not decrease overweight in the general obese population, and because there's so many other things to do for diabetic adults, so many other things. So it's in the it's on the table, but it's way over there at the other end of the table, in my opinion. That's why I call this relatively low efficacy versus all the other therapies we have for overweight and diabetes, etc. Okay, so in this trial, 29 newly diagnosed diabetic adults were randomized to take a typical dose of metformin for 4 weeks, and I checked they were taking a typical dose in this trial. It wasn't like a funky comparator trial. So typical dose of metformin for 4 weeks, or have a single dose of nasojejunal FMT, or both. And this is so fascinating. So here we have the metformin. Here we have in red is metformin, green is FMT, and blue is FMT and metformin. BMI reductions, FMT with or without metformin, substantially better. Fasting blood glucose, FMT does the best by itself. Postprandial blood glucose, these seem more comparable to me, looking at these error bars, but maybe FMT with or without metformin slightly better than metformin by itself. And hemoglobin A1C, FMT, look at these error bars, substantially better. That one is a shock to me. So, is this low efficacy? No, this is exciting. But there's so many other things to use for our diabetic patients. I'm still not jumping to FMT, and it's only this one trial. So, limited evidence, presence of many other tools. So, low efficacy compared to other treatments out there that are much more well known. DM1, hints of promise from early trials. You can look at this later if you want. Irritable bowel syndrome. Of course, this is massively prevalent. Two most recent meta-analyses, both from 2024, indicate FMT is overall not helpful for patients with IBS. No serious adverse events. Maybe patients experiencing pain are better responders. Technically, with the new Rome criteria, the newest Rome criteria, I think it's Rome 4, that would be all patients with IBS have pain. But these meta-analyses maybe are stretching back 2 times when we use different criteria. Anyway, patients with pain may be better responders. Maybe patients who get single donor FMT versus mixed donor FMT are better responders. Maybe patients who get FMT via enemas, colonoscopy, or NJ tube, the rectal methods, or nasojejunal, are better responders than like capsules. I don't know. IBS, of course, is 100 things with one name, but since NDs and other integrative clinicians tend to get IBS patients who've tried everything, and since prevalence is so high, and since FMT is so safe, I have tried it, and I do have some success stories, and I have plenty of didn't help stories as well. But maybe it is worth it to try, especially single dose enemas in IBS patients with pain and where you have clinical suspicion of dysbiosis from their lab results or history or whatever. And I have seen some great success. Oh, here's one case that's good. And I'm not giving you my many failure cases. I'll just tell you that they're there. Chief complaint of IBS, try FMT, enemas or capsules, don't get benefit. But here's a recent case. He just emailed me yesterday, actually. 63-year-old male, the 39-year history of chronic diarrhea and moderate to severe abdominal pain following many antibiotics to treat extensive burns that he got during combat. He was in the armed forces. We give him FMT capsules, 55 caps on day 1, 50 caps on day 2, and then 10 caps per day for a week. No food for 4 hours before or 1 hour afterwards, which is pretty typical for me with caps. His stool consistency normalized and abdominal pain reduced during that 9-day course. Not even afterwards, but already stool consistency normalized. Bonus, his systolic blood pressure dropped 20 to 30 millimeters of mercury, and diastolic dropped 10 to 20. His average fasting glucose dropped 20 to 30 milligrams per deciliter. Fatigue and mood somewhat improved. Brain fog, insomnia, not better at all. And then my last follow-up with him after 10 weeks, after the FMT capsules, diarrhea of 39 years, still gone. Abdominal pain still reduced, not completely gone. And had to discontinue his lisinopril due to normotension or hypotension with his RX. So that's a cool case. A little bit of an outlier. I do have other cool IBS cases, though. So I don't jump to FMT for IBS. Not at all. I used to teach a whole course to integrative medicine fellows in Arizona on IBS. It wasn't a whole course. I'm sorry. It was just a lecture just on IBS for integrative medicine fellows. And I gave FMT a mention, even though I'm obsessed with it. But there's so many other tools to use. So I don't jump to this. Side note here, I want to just look at all the neurological stuff together, which have mixed efficacy and prevalence between all these different conditions, but I wanted to group them together so we could think about them together. Autism. So there was a recent review that looked at 6 observational trials and case papers covering 103 subjects with autism who received FMT, along with 41 subjects with ASD in one randomized controlled trial, of whom 19 got FMT and 22 got placebo. So in that group, GI symptoms improved, and CARS, which is, I think, the most commonly used neurobehavioral health score, improved anywhere from 10% to 50%, with improvement durable to and even increasing at 2 years in one trial. I think the first published trial, Doug Adams in Arizona. And then a systematic review, which included the observational trials plus the 2 randomized controlled trials for ASD, presented a more complex and less clear picture. And so they compared the 2 RCTs. One RCT didn't look at GI symptoms, but it showed no difference between FMT and placebo for neurobehavioral symptoms. The other RCT showed very clinically and significantly statistically significant effects in both gastrointestinal and neurobehavioral domains. And that benefit was associated with decreases in urine 5-HIAA and a microbe in the gut called Eubacterium coprostinoligenes, which I've looked into. I don't really myself treat a lot of patients with autism at all in the past 15 years, but I've consulted for other docs who are treating many times. And this one, coprostinoligenes, something to do with like transforming cholesterol. I'm not remembering the details. Interesting things to find though. And I think it's important not to overclaim when it comes to autism. And these results are relatively preliminary. And anecdotes can only take you so far. But I will say, because of my even like secondary or tertiary involvement with some of these autism cases, helping to manage the FMT safety portion of it, I have heard many moving before and after anecdotes from parents. Even sent me videos of fine motor control or social interactions before and after. I had one person I got close with, a mom of two autistic kids, and she kind of worked a lot with a group of parents of autistic kids seeking novel treatments. And her estimate, if I'm remembering off the top of my head correctly, was that about 25% of kids in her group with autism got a robust response to FMT. And so, the thinking is autism is absolutely multifactorial. And for some, maybe 25%, it's microbiome driving the train. And if you can change microbiome, you really are changing the course of where we're going. Okay, multiple sclerosis. The literature is sparse. 2023 literature review found 15 patients in the literature and did conclude all 15 patients who received FMT experienced improved and reversed neurological symptoms secondary to MS. This improvement was sustained even in follow-up years with no adverse effects observed. Well, that's encouraging. It is only 15 case reports. The only RCT that was conducted was terminated early due to the unexpected death of the primary investigator. But before it ended early, it did find FMT enemas reversed leaky gut in the patients who had it. And I have very little experience myself. It's limited to 2 patients with early relapsing remitting multiple sclerosis. But in both of them, almost all symptoms remitted. And in one of those patients, post-FMT brain spine MRI was no longer able to find radiologic evidence of MS. So that's a very exciting anecdote for what it's worth. One case report did find the Extended Disability Status Scale, EDSS, stabilized for over 10 years in a case of secondary progressive multiple sclerosis. So again, single case report. Parkinson's, also very limited. A July 2025 systematic review looked at 4 randomized controlled trials, 1 observational trial, and 1 case series for a total of 104 subjects. They reported FMT shows efficacy and safety in Parkinson's treatment. And they had some things to say about microbiome. And I will say, looking at this systematic review trial, we see these two who had the highest effect by far. This was Cheng and DuPont. These 2 trials were the only 2 to use FMT capsules. The other ones were using other administration methods. So they used about 50 capsules over 3 weeks in one trial, or about 150 capsules over 3 months in the other. So can we guess that if you're going to use FMT for a patient with Parkinson's, you should use capsules? Maybe. Seems like a reasonable guess. And then the most recent randomized controlled trial, November of 25, compared a single dose of fresh, meaning non-frozen FMT, via colonoscopy, compared that to placebo in 30 patients with mild to moderately active Parkinson's. Very successful engraftment, and they reported that FMT effectively alleviated motor and non-motor symptoms, thus facilitating defecation and improving quality of life. Alzheimer's. 2022 systematic review found favorable animal studies and narrative reviews, but only reported 2 case reports in actual humans in the literature. A 90-year-old with C. diff and Alzheimer's got 2 doses of FMT from a 27-year-old donor and experienced cognitive improvements. And then an 82-year-old with C. diff and mild cognitive impairment. His mini mental status exam result was 20. He got 1 dose of FMT from his cognitively sound 85-year-old wife and experienced cognitive improvements. His mini mental status exam score improved to 29, which is in the unimpaired category. So 2 case reports only gets you so far, but that's what we have to go on so far in the literature. Neurological, I've been peripherally involved with FMT for 6 different patients with ALS, Lou Gehrig's disease, amyotrophic lateral sclerosis, but unfortunately, none of them have perceptibly improved. There are 2 really exciting case reports. They were both separate patients who were ventilated, intubated, and non-mobile. And after FMT, they were, each of these 2 cases were able to breathe, eat, and stand unassisted. So, my word, exactly the outcome that you would want. But in the very, very far progressed patients with ALS that I was involved with, not my patients, not primary, even secondary treating doctor, just a consultant on the FMT portion of it, but none of those cases perceptibly improved, unfortunately. Oh, and there was 1 randomized controlled trial, and there was no difference between FMT and placebo in that 1 randomized controlled trial of FMT for ALS. Okay, our last category here, low efficacy, low prevalence. And we just have 2 things here, chronic fatigue and pouchitis. So chronic fatigue, or ME, 1 early retrospective paper reported that in patients with CFS-ME being treated with FMT for other indications, 35 out of 60 had their fatigue respond. This older paper did not use any formal diagnostic criteria in their descriptions. I think they were just kind of taking patients at their word of mouth, or taking patients at their word. Do you have chronic fatigue, and did you improve, and reporting that. There's only been 1 randomized controlled trial of FMT for chronic fatigue, in which they used a single dose of FMT versus a control group using their own stool. They got their own stool. No difference between those 2 groups. And so, based on this literature, I would be unlikely to use FMT for a patient with chronic fatigue. But it does remind me of my previous perspective on autism. So I had autism in that low efficacy category in my mind for years. There were no published papers, and I worked with half a dozen autistic kids early on in my practice using FMT. And the parents and other caregivers were thinking, this could be microbiome related, let's try fecal transplant. I gave up to 10 FMT enemas, or sometimes upper GI administration, for a limited period of time, which is what I was always doing at the time, and I did not see improvement. So I spent years and years telling people, I think there's a low chance of any efficacy of FMT for autism. And then the Adams group in Arizona published their trials, and I had to change my estimation. So I would wish for that. Maybe we're just dosing it wrong for chronic fatigue. Maybe Barodi in his early retrospective paper, maybe he was right, and we're just doing it wrong. I don't know. But as of right now, I would be unlikely to use it for that indication. There's been 1 paper on pouchitis, there's been more than 1 paper, but there's a systematic review and meta-analysis. I'll tell you what they reported, and I'll tell you what I think about it. So here's the title, FMT for chronic pouchitis, a systematic review and meta-analysis. So they concluded FMT is an effective treatment for chronic pouchitis. They say the pooled overall remission rate was 15%, and there were 7 studies with 94 patients included. So, okay, that sounds encouraging when you read what the authors have to say. But of those 7 studies, 6 out of the 7 were observational. And lactobacillus and bifidobacterium probiotics and metronidazole both have about 70% efficacy rate at inducing remission in chronic pouchitis. So I would say it's not an effective treatment for chronic pouchitis. You can't conclude it's effective by saying observational trials show an overall pooled remission rate of 15%. So I respectfully disagree with these authors. And then there was this RCT, the 1 RCT that was done, the trial was terminated early due to futility, completely did not differentiate from placebo. So, I said at the beginning, I would consider FMT for every single indication here. And I have used it for pouchitis. I think sometimes I've seen benefit, but maybe was just regression to the mean, or I was, thinking there was benefit when there wasn't, and so was the patient. So I am not excited about using FMT for pouchitis. I would much rather use certain probiotics and other things. If a patient asked me for it, would I try it again? Yeah, I guess, but I wouldn't be excited. Okay, more on safety. So here's some extra special thoughts. So many systematic reviews emphasize that FMT with a properly screened donor is safe with a vanishingly small risk of serious adverse events. What are the adverse events? So from all methods of administration, we see self-limited diarrhea, constipation, nausea and vomiting, increased flatulence or abdominal pain, 1 to 2% of the time, bloating as often as 40%. We might see fever as often as 3 per 1,000 instances of FMT. Before FDA changed the way we screen things, before we looked for multi-drug resistant organisms and screened for STEC and EPIC using nucleic acid amplification. So before we did that, there were 2 cases of bacteremia, including 1 death in very, very highly immunocompromised people, even though FMT is generally safe in immunocompromised people, and 7 cases of STEC diarrhea. So FDA now mandates MDRO testing and that we use nucleic acid amplification techniques, not the less sensitive immunoassays, to look for pathogenic E. coli in our donors. And if you're giving via colonoscopy or endoscopy, perforations and aspiration pneumonia, known consequences of endoscopy, have occurred during FMT administration, maybe a little under 7 per 1,000. So that's a possibility. Okay, other anecdotes. So I've got in my lab just last year 2 complicated GI patients, including one Crohn's patient with paradoxical reactions to like every IBD drug, a history of like 15 different abdominal surgeries. So 2 different GI patients took FMT caps from the same donor from my lab, processed around the same time, developed a similar constellation of new symptoms within days of taking FMT caps. Nausea, diarrhea, abdominal pain, intense fatigue lasting weeks. Actually, for the one patient, it's still going. He's the super complicated one, though. I'll take a moment and tell you a little bit about him. I actually since then tried using Alinea with him with great but transient response, rifaximin with him, and using another FMT donor who no other recipients from my lab have had bad outcomes with, but he had a similar outcome from that one. So I don't know if this was a coincidence, and he's just a very sensitive person. Like in terms of safety, like I saw a patient yesterday, young man who gets intense fatigue, brain fog, nausea, cramping, bloating with most foods, most probiotics, most antibiotics. And he got a reaction like that to FMT as well. But that's not like an FMT thing. That's a he's super reactive thing. And I wonder if I should put these patients in the same category. I don't know. Medicine's confusing. I did take it very seriously though. So even though all other recipients who received FMT products from the same donor, processed around that same time, reported no side effects, or typically self-limiting side effects, which is the ones I talked about in the previous slides: bloating, very common, constipation or diarrhea, common, some nausea, self-limiting for a week, maybe 2 weeks max. Those are the common ones. So patients just getting those typical self-limiting side effects or no side effects. And in some cases, of course I wouldn't keep doing this, significant benefit. So there was one additional patient with MS who was constipated before FMT, who moved to loose and sometimes frequent stool after FMT. And this was, again, the same batch. So I took the step of removing all the product made from that donor from circulation and have not used that donor since, just out of an abundance of caution. I also did intensive testing with both of these patients and the donor and thawed caps made around that same time. And we got like nothing. None of us found really anything worth writing home about from any of that testing of thawed caps or from these 2 different patients testing. And I should update this. Yeah, one patient got transient benefit with rifaximin and then durable reversal of those symptoms from nitazoxanide from Alinea. And the other one, I could say, yeah, got, he can repeatedly get really great benefit from about 3 days of nitazoxanide that doesn't last more than a week. Nitazoxanide is fascinating because it's antiprotozoal, as we know. It also has substantial antiviral effects, and this patient with Crohn's may have some viral issues. This is more in the weeds than any of us needed to go, probably. But it's safety concerns. Oh, God, I forgot. I went through all of this complicated Crohn's patient. This patient, before FMT, in his microbiome had about 35% lactobacillus and other lactic acid producers, and we think he actually experiences bouts of D-lactic acidosis, where he feels drunk and has central nervous system effects. And looking at his older microbiome reports, he had no acetoaminococcus, and the donor that I removed from circulation, competitive athlete, and microbiome had 3% acetoaminococcus, and which is not in any FMT lab considered a red flag organism or anything to not use. It is an ammonia producer, but at low abundance, not at harmful amounts as far as anyone knows. And then this complicated patient's post-FMT microbiome still had 38% lactic acid producers, but also went from 0 to 15% acetoaminococcus. So I have wondered if his bad effects post-FMT were related to this bloom of acetoaminococcus abundance. I don't know. So this is not in the literature, or I don't think other labs do this, but it's now tentatively on my lab's red flag list when I'm looking at donors. A patient of mine reported getting blastocystis from FMT from a different lab, not my lab. She didn't share the name of the lab. I didn't verify any labs of hers or anything. That's just an anecdote. And then who is this? This was an elderly patient of mine who had antibiotic-resistant C. diff colitis and was doing DIY home FMT from a related donor for this moderate to severe antibiotic-resistant C. diff colitis. Stool test results were delayed until after the scheduled treatment date, but the family decided to go ahead and do FMT anyway. And then the donor stool tests after FMT revealed blastocystis hominis, Entamoeba histolytica, and Dientamoeba fragilis. This wasn't like a donor from my donor bank. This was a relative of the patient who was getting screened, and they were doing FMT. And so they were all not even just rare, but abundant in all 3 stool samples that were collected. However, the patient's C. diff colitis was durably cured, and O&P times 3 of the patient 2 months later did not reveal protozoans or any parasitosis. So just an interesting anecdote from my own practice. A couple other labs, or anecdotes. In one U.S. lab that some colleagues of mine, people I know run, I'm not affiliated with this lab, they reported a series of about 5 patients using FMT caps for C. diff, reported debilitating cramps for a couple hours after taking the caps, so they also removed that donor from circulation. Yeah, they did cure C. diff in all those patients as well. Another fun story, in my practice, I screened the roommate of a patient with IBSD to be the patient's FMT donor. At one point, the donor left town for a 10-day Vipassana meditation retreat, came home, collected stool and returning, and after doing FMT from that sample, my patient reported being flooded with an ecstatic, blissful sense of calm and peace. So what, was that placebo effect? He knew his donor had been on this meditation. Or are there ways in which meditation can change or benefit our microbiome and the effects on the vagal nerve or neurotransmitter? I don't know. Blows my mind, though. Other safety concerns. Some reviews estimate the risk of having an IBD flare after FMT, maybe as high as 5 to 15%. But the confusing thing there is this is total risk, not risk compared to placebo. So this might just be tracking the natural risk of entering a flare during a given period and may actually be a lower risk than those who didn't have FMT. For many years, I encouraged patients to do enemas instead of capsules, or colonoscopy administered FMT versus nasojejunal for patients who are hospitalized, because I thought putting large bowel microbes in the large bowel seems less likely to cause problems. And the literature showed better efficacy for C. diff with the lower GI approach. I was also concerned for people with impaired migrating motor complexes. The upper GI FMT could aggravate SIBO. I thought, okay, SIBO is small intestine bacterial overgrowth. If you're putting more bacteria in the small intestine, large intestine bacteria in the small intestine, maybe you could aggravate SIBO. But then, in 2017, an open label trial using 6 doses of nasojejunal tube FMT for 7 patients with chronic intestinal pseudoobstruction and hydrogen SIBO found that bloating and abdominal pain significantly improved. And the SIBO breath test normalized in the majority of them. Interesting. Open label trial, though. And then in 2020, first randomized control trial of FMT to treat SIBO was published. 55 patients with hydrogen SIBO got 16 FMT caps or placebo caps once a week for 4 weeks. And look at this. Statistically significant improvements over time with indigestion, diarrhea, constipation, abdominal pain, and reflux. That's pretty impressive. And what do we have here? Oh, methane concentration, hydrogen concentration, looking at FMT after 6 months versus the placebo group or baseline. Okay, real significant changes in hydrogen concentration there. So that's meaningful. Okay, and then in 2024, a group of 218 patients whose chronic constipation was treated with FMT via NJ tube were divided into those with and without SIBO. The cure rate of the chronic constipation, it was statistically significantly higher in the SIBO group. And the number of complete spontaneous bowel movements per week in the non-SIBO group went from 1.4 bowel movements a week to 2.4. And in the SIBO group, it went from 1.27 to almost 3. Statistically significant, nice low p-value there. So that's pretty compelling as well. So then for about the past 2 years, because of these studies, I've told patients, practice beats theory every time my SIBO concerns were misplaced. And I've done my best to stop emphasizing enemas over capsules. And this gets a little bit wonky, but in June, Dr. Jason Haverlack, brilliant PhD microbiologist and naturopath in Australia, posted this fascinating study to the forum of the Gastroenterology Association of Naturopathic Physicians. Elegant series of experiments where they used PCR to look at the microbiome from duodenal biopsies of human subjects before and after endoscopically administered FMT. And what they found was colon microbes, including some anaerobes, which usually don't hang out in the small bowel, engrafted in cultured human duodenal cells after FMT, and those cells acted differently. So they wrote, these data raise a cautionary note that unrecognized short and long-term consequences of FMT may emerge in clinical practice, in particular for off-label use where mechanism and efficacy remain unknown. I do think this is a valid concern to think about and pay attention to. However, I will say these risks are very theoretical, and those local changes, when you read the study, they included decreased macronutrient metabolism. You don't need to metabolize macronutrients in the large bowel, but you need to metabolize them in the small bowel, and these were small bowel cells. But also increased mitochondrial expression. Is that a good thing maybe in these duodenal cells? So unclear about what sort of safety signal we're really getting to me. And this may be more of a critique of endoscopic or NJ tube administered FMT, which is dispensed to the duodenum or jejunum, than capsule FMT, which is designed to release its product in the distal ileum or proximal colon. Could explain the persistence of SIBO in some hard-to-treat cases. Okay, special populations. So in general, in pediatric, elderly, and immunocompromised patients, FMT appears to be robustly safe. But according to most guidelines, pregnancy is considered a contraindication for FMT. There are 4 case reports of using FMT in published patients, including identifying cross-generational bacterial strains. So that is to say, they identified a strain from donor in baby's stool. So I have a different opinion, which I know is controversial. And my opinion is we need to consider all risks and benefit for this protected special population. And I think clinicians and pregnant patients should weigh the known risks and benefits of FMT and the potential unknown risks of FMT against the known risks, and those include obstetric risks, immune system risks, neurobehavioral risks, metabolic maternal immune activation sequelae associated risks associated with continued dysbiosis and C. diff colitis. So I think it should be up to each individual pregnant patient and their clinicians to work at weighing the comparative risks and benefits. Okay, politics and availability. Getting towards the end. How have we regulated medicine over time? So this is my great-grandfather, Michael Nestor, who graduated medical school in 1906 before the Flexner Report, and he went to medical school for 6 months. Why 6 months? Because the entire University of Maryland Medical School course of study was 3 months long, and he decided he hadn't learned it well enough, so he took the entire course again, an additional 3 months. For 6 months, and he did a 1-year residency, and then went and practiced medicine and public health for the rest of his working life. So medicine used to be regulated real differently. Also, a doc of my great-grandfather's generation, Dr. Ben Eisman, lead author of Eisman et al., our first modern American report of FMT. Dr. Eisman wrote, "In the early days of oral antibiotics, we were plagued by frequent diarrhea in our patients due to presumably killing off intestinal bacteria. I was chief of surgery at the VA in Colorado and simplistically considered merely reintroducing normal organisms to counter such absence. These were days when if one had an idea, we simply tried it. It seemed to work, and I wrote it up and made a small splash." So that was his recollection of being the lead author of the first ever modern case series on FMT. Okay, so how is it regulated in Europe? Differently in different countries. Regulated as a tissue or cell or equivalent in Australia, Belgium, and Italy. Regulated as a drug or medicinal product or equivalent. Therapeutic intervention in Finland, and just case by case in a bunch of other, a handful of other countries, including the Netherlands and Denmark and Belgium. And the EU Substances of Human Origin guidelines, or SOHO, they currently cover blood products, stem cells, reproductive cells, and breast milk. And as of August 2027, they'll also cover FMT products as well. So that's coming down the pipeline in Europe. Okay, availability. So in the US, we have 2 FDA-approved products. Rebiota, which is FMT enemas, and then Valst, which is the FMT capsules. I gave this talk for an Australian audience, so I talked about the Australian Registry of Therapeutic Goods as well. There are a bunch of places you can get in-house prepared FMT for patients with refractory C. diff infections. As I mentioned earlier around the legal part, FDA has always made an exception for clinicians who have their own FMT bank or hospital systems who have their own FMT bank. Using that bank to treat patients with C. diff not responding to standard therapies is fine and allowed. So there's a few, biome-basics.com, naturopath, colleague of mine, treats patients with CDI. Sun Valley Natural Medicine at svnaturalmedicine.com. Again, naturopathic colleagues. PurityClinic.com in Santa Barbara, California. All of these are using their in-house prepared FMT for patients with C. diff, and I think they all do a great job. Here are some other well-known clinics. Mount Sinai, Mayo, Brown, University of Massachusetts, Children's Hospital of Philadelphia, etc. Some international options. These are not exhaustive. These are just ones I'm somewhat familiar with. Tameout.com, probably the busiest of the international clinics. They're in the UK. I've had dozens of patients go there over the years. I think they do a great job. Microbioma.org or microbioma.org. They're in Spain. I have had them mail FMT to patients in the United States. Gezonde Darmflora in the Netherlands. They seem like they're doing a great job. I've had them mailed to patients in the US. IPPM is the Institute for Personalized Progressive Medicine, I think is the second P. Biombridge.com, they're in, is that Slovenia or Slovakia? I had at least one patient go there. Biombridge.com, that's in Panama City, Panama. That's the one, asterisk, conflict of interest, that I am co-founder of. My partner down there is a pediatrician, medical doctor. I think we do a great job down there. Santa Vive is in Mexico. I've consulted with them as well as with Purity Clinic and others. And then, of course, the granddaddy, Center for Digestive Diseases.com in Five Dock, Australia, outside of Sydney. That's Dr. Tom Brody, who was publishing about this back in the 80s. Autoclave products, I mentioned this earlier. Colleague, friend, former student of mine who co-founded Thena.com. And so this is generally recognized as safe, used as a supplement, sold directly over the counter. And then individuals can order for research purposes from NIST, National Institute for Standards and Technology, I think. They have a reference FMT product researchers can order. And then I have, again, conflict of interest alert, I sell FMT aliquots, capsules, and enemas directly to individuals who are interested in researching engraftment of microbiome in their own microbiomes without any medical claims or anything like that. Okay, so DIY FMT. I always tell people, if you can bake a cake, you can make FMT enemas at home. Even if your cakes turn out terrible, you can still make FMT enemas at home. It's not rocket science. It's not hard at all. And I have coached over 1,000 patients on doing this at home safely and sometimes with great effect. I think as effective as FMT from any lab. Making caps at home has more of a learning curve. And initially when I started coaching people or families on doing this, it was mostly married couples who were both medical doctors and had a kid with inflammatory bowel disease. And so they were highly motivated, felt confident with the learning curve, getting the technical know-how to operate a centrifuge, et cetera, it's micropipette, et cetera, et cetera. And they had the money because just the centrifuge itself is $5,000 to $10,000, and then the rest of the equipment is another, $1,000 or $2,000. But since then, I've coached other people, filmmakers, stay-at-home dad, people without technical backgrounds who've decided to take the expense and master the learning curve. So it's totally doable. And for your patients interested in doing DIY FMT, I've got some assets for you. So you can go to markdavisnd.net/FMT-forums, and you can download screening documents, how to screen a donor, what are the criteria and what are the lab tests, the stool tests and blood tests that you should order to properly screen a donor. So you can download those, and also DIY FMT for a bunch of different indications. How does somebody do this at home? What are the instructions you should give them? You can download those. There's no charge, and also no charge for this. You can watch videos on how to do this that are helpful and instructive for some people. You do have to put in the password FMTFTW to access those videos. Okay, so the cost. I did run all these slides through a large language model to say, please identify any errors or mistakes or misphrasings or typos or whatever. And one thing the large language model said was, sticker prices vary a lot and they might have different deals with different insurances. So, the sticker price of Rebiota, when it originally came out, was about $9,000 per enema. And for Valst, it was about $1,500 per capsule. It's usually administered, you get a dose of 12 capsules. It's recommended to take 4 capsules a day for 3 consecutive days. But this, like any pharmaceutical product, varies. And the cool thing about this is, with the FDA approved products, is insurance is pretty much almost always covering it. So huge sticker price that insurance swallows. So for your patient, they could be paying nothing or almost nothing. And I think these products are great. I've seen them reverse refractory C. diff infections. And if you have access, your patient has access to them, great, go for it. The in-house, international, and research products, so that was like the naturopathic clinics who treat C. diff I mentioned, the university and the hospital and Mayo and CHOP and all those. And then international ones that I mentioned, like T-Mount and the ones in the Netherlands and Spain, and research products like NIST and my lab probiotic infusions. Enemas are ranging anywhere from $350 to $1,200 per. I wrote 120 to 150 milliliter enema, and capsules are ranging anywhere from $25 to $50 per capsule. The autoclave capsules, of course, these do not have live microorganisms. So anytime you want engraftment to be the mechanism of action, you would not use the Thena, the autoclaved capsules. But I do think that there is benefit to, I don't know if it's the postbiotics or bacteriophage, or actually it wouldn't even have bacteriophage. That would be the filtered FMT. So really it would just be postbiotics. And this is much more affordable, ranging from $5 to $7 per capsule, depending on how many the patient is buying. And I think this is helpful in some cases. And then DIY FMT, it's the cost of finding a donor and screening a donor and buying some equipment. And for enemas, where you don't need a centrifuge, this can be it's going to be like $100. Sometimes insurance covers all the donor screening, and you're just getting like a blender and some gloves and some Chucks pads and some stuff like that. And cost, for regaining your health, priceless, of course. All right, last section. What are we doing aside from just giving FMT? One thing we think about is prebiotics, and this is really almost entirely the prebiotic I have given when I give a prebiotic is apple pectin, because it's the most represented in the literature. One randomized controlled trial of FMT for ulcerative colitis gave patients a pretty big dose of pectin, 20 grams per day, PO, and found that the pectin group had significantly lower Mayo scores as well as better and longer lasting engraftment. So I give people the FMT and then to have them start the pectin right after FMT or at their last dose or sometimes during FMT. And then an open label trial of FMT plus 8 grams of pectin, PO twice a day. So similar dose was 16 grams in the day, just spread out. For patients with slow transit constipation, showed the number of complete spontaneous bowel movements per week really got substantially better. So this is open label. They were giving FMT and pectin to everyone. I forget what BSFS is, what that stands for. Looks like it improved, whatever it is. But complete spontaneous bowel movements, moving from 1 to almost 5 per week. That is a great outcome. Great outcome. Prebiotics. So psyllium, a randomized controlled trial of FMT for ulcerative colitis, randomized participants to 10 grams of psyllium husk or placebo. Psyllium did not improve outcomes and may have actually blunted them. The FMT plus psyllium group had less remission and more diarrhea than the FMT plus placebo group. It was greater than 0.05, so not statistically significant. But I do not recommend psyllium as a prebiotic along with FMT because of this one trial, at least for patients with ulcerative colitis. And then microcrystalline cellulose. Remember that forearm trial I mentioned of FMT for patients with severe obesity and metabolic syndrome? They had substantial benefits in insulin sensitivity if they did FMT, but not if they had fermentable fibers like acacia. In fact, that made it so the FMT did give benefit only with non-fermentable microcrystalline cellulose. So, and not with no prebiotic. So I have not really used FMT for patients with metabolic syndrome, severe obesity. I have used FMT for patients with Clostridium or Clostridioides difficile infections and severe obesity. I have not seen miraculous recoveries, but then again, I wasn't giving it with microcrystalline cellulose. I've never prescribed microcrystalline cellulose, but I guess I would consider it. Okay, diet. In addition to prebiotics, let's think about diet. So, a hard to interpret 2022 trial randomized ulcerative colitis patients to just FMT, FMT with the ulcerative colitis exclusion diet, decent diet with some evidence behind it, or just the diet. FMT was given 3 doses, 1 through colonoscopy and then 2 enemas and from a single donor. And ulcerative colitis exclusion diet is a kind of like a classic naturopathic anti-inflammatory diet. So it did use a single donor, and okay, group 1 was just FMT. Look at this, worse results. So really, the diet by itself gave good results, and the diet didn't give benefit if you gave FMT, and FMT by itself had the worst results for response at week 8, remission at week 8, and endoscopic remission at week 8. So this is interesting, and makes me think, yes, use beneficial diets for ulcerative colitis. I do all the time, and you should as well, if you're familiar with how to use them. But combining them with FMT, paradoxically bad effect. So have I used FMT for patients on anti-inflammatory type diets? Yeah, definitely. Have I seen benefits sometimes? I have. Have I seen no benefits sometimes? Definitely. Is that the reason? God, maybe so. So here's another trial. And in this one, they gave 7 doses of colonoscopic FMT and used multiple donors. So there were 2 groups, FMT plus inflammatory diet or no additional treatment. So they weren't teasing out, but they were using this category, FMT plus inflammatory diet. And versus no additional treatment, yes, statistically significantly more patients in clinical remission, in endoscopic remission. And then those who continued the anti-inflammatory diet were more likely to be in endoscopic remission at 48 weeks versus the no additional treatment group. So we can use FMT for patients on anti-inflammatory diet, but maybe still better to separate them out, and we might get even better outcomes. Antimicrobials. So pre-FMT antibiotics all reduce donor microbiome engraftment in patients with IBS-D. Pre-FMT antibiotics for IBD seem like they do improve outcomes in the literature, but they're not always indicated. I have successfully cured RCDI using FMT with no antibiotic pretreatment, even though pre-FMT vancomycin is standard of care. Head-to-head comparisons have not been done, and I recommend trying FMT. I mean, it really, really, really 100% depends on the patient in front of you. Generally, the patient in front of me, 95% of the time, has already had at least 1 round of vancomycin by the time they get around to contacting me. Humans and mice with intestinal candidiasis are less likely to achieve durable remission from refractory C. diff infection. Mice with candidiasis more likely to achieve durable remission if they are pre-treated with fluconazole. So worth considering if you have the right patient in front of you. And my general philosophy with FMT and antibiotics or antimicrobials of any kind is, if a specific antimicrobial helped in the past with the condition we're trying to treat with FMT, try that antimicrobial again. That could be an herb, could be an antibiotic, could be an antifungal. So somebody says, oh, weirdly, I got antibiotics for my sinus infection or my urinary tract infection. And for a period of time, my diarrheal disease, my chronic idiopathic diarrheal disease significantly improved before it came back. Okay, let's try that antibiotic at that dose or similar again before FMT. That's my philosophy. All right, I've been talking for a long time. To sum up, the ick factor about FMT is still real, but it's way less real than it was when I started doing this 15 years ago. The risk-benefit ratio is great. FMT can be super accessible, very, very affordable for somebody willing and able to do DIY FMT. And there are labs out there, my lab, and as you saw, a ton of other labs out there available for people who don't have a donor available to do DIY FMT. And there are an amazing amount of common and severe conditions that respond robustly to FMT. So this is my email address. Feel free to contact me if you have any questions. If you are a clinician. Now, if you're a non-clinician watching this and you want to chat with me about FMT, please make an appointment. That's, my business, how I make a living. But if you're a clinician, delighted to talk to you all day long. You can actually even make appointments to chat at no cost, just because I love this therapy. I want more people to know about it. I want you to know about it. So I do little consults at no charge. All right, and then here are all the references. I'm just going to scroll through these because I'm not sure if we're making this PowerPoint available. And if you're interested in a particular reference, I want you to be able to pause it at the right point to look it up if you just have this video and not the slides. So I wish you all well in your journey of using FMT as a clinician. Enjoy these tons of references and have a great day.